Thank you all for joining. If you have any questions at all, please feel free to drop them into the chat as we are doing this webinar. My name is Gabrielle. I'm the Executive Director from the Lukin Center for Psychotherapy, and we are here today to kind of discuss OCD in general, what the diagnosis will look like in different ages from child to adults. But we wanted to share about why Lukin Center and why we're coming together today. So we are here because it's really important that Lukin Center and the Center for Developmental Psychiatry gives our clients a coordination of care, evidence-based care, which addresses both emotional and developmental needs. Our therapists and psychiatrists work together to create accurate diagnosis and align treatment plans. This leads to more effective and compassionate and seamless support for clients in care. I'm going to pass this on over to Dr. Patel to share about what OCD is in the first place.
Yeah, thanks, Gabby. So my name is Divya. I'm a child psychiatrist as well as an adult psychiatrist. And I'm really happy to be here to talk to you guys about OCD. I think OCD has been very much the headline recently around what it is. So I'll start off by just going over what is OCD, right? All people that we deal with that have OCD share some core features, and they include obsessions and or compulsion. So that's where you get obsessive compulsive disorder from. Usually these obsessions and compulsions have to be distressing, time consuming, and impairing in order for us to diagnose you with something like OCD versus, let's say you're having some of these thoughts, but you're able to function. If it's not distressing, then likely you wouldn't get that diagnosis. Obsessions are usually recurrent, persistent, intrusive in nature. And so you might hear people describe unwanted, intrusive images or thoughts that really cause a lot of distress and anxiety for them. That's usually a hallmark of obsessions. It's very different from excessive worrying or about like real life problems, for example. Usually these are unwanted random images or thoughts that are not in line with, let's say, your regular worries or your regular life. And you can recognize that it's irrational. You feel that this is something that doesn't make sense. However, you have a hard time suppressing it or dealing with it. So that's usually what marks something as an obsession and getting you closer to a diagnosis of OCD. Compulsions can or cannot be present with OCD, and usually they're a result of behaviors to neutralize some of that distress that you might be feeling from the obsession. So usually it's you have this intense intrusive thought, unwanted image, and then to neutralize some of that anxiety that you're feeling from it, you engage in some compulsive behavior that brings down that anxiety. And so now it becomes sort of like a pattern that, again, you have a very hard time suppressing. Usually people start believing that the compulsions will prevent whatever the fear might be. So, for example, a common example is you may feel that if you don't do a certain ritual, that someone you love might die. And so you do the ritual or the compulsion to relieve some of that anxiety that you feel from this feared event. Usually compulsions, again, I would go, they can be a myriad of different actions, ritualized behaviors. Usually you'll think of like checking behaviors, ordering things in certain places, hand washing if there is a fear of contamination. But compulsions can also be mental. And so again, I think it really points to speaking with someone who has experience diagnosing OCD, because you can have mental compulsions. You can have mental checking, mental things that you're doing to relieve the anxiety, but no one can see that. You're not actually doing any actions. You're sort of just doing mental compulsions to relieve some of those fears that you might be having. That was a lot, Gabby. Do you have any questions on that? Do you think I should add on anything else?
No, I think that was a great little segue into it, and I appreciate that. So if anyone does have any questions that even come up, please feel free to drop them into the chat, and I'd love to pass this on to Dr. Lukin to share his thoughts about it too. And what do you do to diagnose it?
Sure. So, I mean, the first thing that usually comes to mind is that when people are coming in, they're really uncertain for the reason of some of their worries, and often they come from either potential other providers who are not specializing in OCD and are being diagnosed just with generalized anxiety. And to kind of, to Dr. Patel's point, to differentiate between general anxiety and OCD, it could be quite challenging because, one of the hallmarks, as was discussed before, are these intrusive, unwanted thoughts, something that the person actually doesn't want to be having, which is sort of different from the everyday worries that people have. So one of the major things that I do when I meet an individual and there's a potential of a diagnosis of OCD is I try to lay out how typically OCD works in people's everyday life. And then I ask them to be detectives for themselves for the next couple of weeks, just to see whether they can really understand how it plays out in their lives. So one of the things that I always ask them to do is kind of like lay out the plan of like, okay, are you noticing that there's a thought that you don't want to be having? What we usually call a spike. How intense is it in your everyday life? And also, I try to ask them to pay attention to a couple of things. The compulsion part of it is what they do, as Dr. Patel had mentioned before, to relieve some of that anxiety. I kind of try to break it into three different things. The behavioral compulsion, are they really doing something to alleviate the anxiety? And that could be the basic ones that most people are familiar with, is like checking or washing. Are you doing it? How long are you doing it for? The other two things I always ask them to think about is what's usually called reassurance seeking. Are you actually asking somebody else to make yourself feel better? One of the simple example would be like, oh, did I turn off the stove? Oh, is the door locked? And if you're finding yourself asking the same question over and over again in the hopes of relieving some of that pressure. The last thing I ask them to do is to notice, like, sometimes the compulsions are easier to see because they're behavioral, it's something that you're doing. Sometimes it's a little bit harder because it's something that people do internally. So it's almost like they're having a conversation with themselves. They start to worry about something that they really don't want to, like, oh, is my gas stove on? Something that really is not something that they want to be thinking. And then there's another part of themselves that jumps in and says, oh, don't worry about it. It's okay. The difficult nature of OCD is that it's obsessive, meaning that it happens over and over and over again. Although in the moment, some of those feelings begin to decrease and a person feels better. Because of this incessant nature of OCD, the same intrusive thought comes up again. And it's this sort of cycle that people are suffering through that really brings it into either a psychiatrist's office or a psychologist's office. So that's really the pattern that I like to kind of put forth for some of the clients that come in, to just test that out. Often what I find, if it is in line with OCD, people come back the next week or a couple of weeks later and say, you know what, doc, you're absolutely right. The way you describe it really maps on real nicely to what's happening for me. And the reason I like to do that is because often people then have a stronger buy-in to actually do the treatment.
Awesome. That's such a great point. Sorry that we have another person coming in. Come on in, everybody. Thank you for joining. Thank you, Dr. Lukin. I would love to then pass it on to Jason just to share about medication and how it works with OCD.
Sure. Thank you. Well, before talking about medication, actually, I'll also mention that therapy is also incredibly important. I'm sure we'll talk about that after. So I'm going to talk about the medication, but OCD, most things, but definitely OCD, the combination of medication and therapy is really important. Which is part of why it's so wonderful that we can kind of work together in these cases. But in terms of the medication, the mainstay of treatment really is the SSRIs, which stands for selective serotonin reuptake inhibitor. So that's medications like Prozac or Zoloft, Lexapro that people may have heard of. Typically in children, we see children and we see adults, but in children, usually we use like Prozac and Zoloft mostly. Even in adults, actually, I prefer those two medications because one of the important differences between OCD and other conditions like anxiety and depression is that typically OCD requires higher doses, actually, and it takes longer. So Prozac and Zoloft, those two medications, have higher doses available, higher relative doses compared to some of the other medications. And so because I know when I'm starting to treat OCD, we might need to go to a higher dose. It's good to pick a medication that you know you're not going to get kind of stuck. Because some of the other medicines, you could increase the maximum dose, then you could get kind of stuck. Actually, one of the unique features of OCD treatment is that we'll actually sometimes go above the normal maximum dose, which is a little bit unusual. So, the maximum dose for Prozac, for instance, is like 80 milligrams. You could even go to 100 milligrams for an adult at least. So those are the medications I typically would start with. Because, like I was saying, it can take longer. It can take up to 11 weeks to work. Whereas for normal anxiety or depression, it usually takes more like 3 to 4 weeks. If you start, usually with all medications, you start low and go slow, as we say. So you start at the lowest dose and then you kind of increase gradually over time. Normally, you'd wait like at least 3 or 4 weeks before kind of increasing the dose. But because you might need to get all the way up there, it could take months. And so this kind of depends on the severity. So if it's really bad, I mean, OCD unfortunately can get really, really bad where there's almost like a total cessation of normal life. If it's really bad, sometimes I'll kind of go faster. That's obviously depends on the situation and depends on the family and all these things. But that's typically what we start with. If an SSRI is helping a little bit, but not enough, you can add in what's called, you can augment with another medication. Risperidone is like the one that has the most evidence. Risperidone is it's an antipsychotic, so it's used for many different things. But when you combine it with an SSRI like Prozac, it boosts the effect. And also because it can be used as like a mood stabilizer. Some people with OCD have a tremendous, especially children, can have a lot of agitation because these thoughts are kind of torturing them. These are intrusive thoughts that are often sometimes violent in nature, like very, very, very uncomfortable things that make a person feel incredibly upset when they're experiencing them. And they can really develop a lot of agitation. So a medication like risperidone can be used to also help with that agitation, which I've found to be really helpful. Maybe I'll comment quickly on the potential side effects. So basically, almost every psychiatric medicine can cause upset stomach, headache, some dizziness, and things like that. For the most part, the SSRIs are really pretty mild. We don't see, that many terrible side effects. They can sometimes cause a little bit of weight gain. Sometimes, especially in children, they can cause what's called activation, which is kind of like an increase of energy, increase of anxiety a little bit. And sometimes it could even cause agitation, which is obviously an ironic problem. We're trying to calm things down, and it could cause that. But in general, they're very mild. So there's a lower barrier of entry, so to speak. Medicines like risperidone are different because that can cause a lot of weight gain. It can cause high cholesterol. It can even cause diabetes. It requires blood work to be done to monitor. So you kind of need to have a bigger, everything in medicine is a cost benefit analysis. So you need to see a much bigger problem or a much bigger benefit to warrant, in my opinion at least, warrant going to a medicine like that. So typically, if you're going to go on a medication for OCD, it's probably going to be one of those, the SSRIs. Yeah, so that's basically the rundown on the medication. I think later on, if we have time, maybe I can talk a little bit about when to use medication or whether to use medication. But that's like the basics of what we actually do.
That's great. Thank you so much, Dr. Dean. I would also then love to pass on to Alexa, who's a licensed therapist here at Lukin Center and a creative arts therapist as she works with little ones. So I would love your feedback if you can kind of just share about working with kids and treating OCD and what it might look like kind of with different ages.
Yeah, of course. Thanks, Gabby. So with kids, it presents similar to how it does with adults, but obviously different. So they often feel fear in their bodies more than they can explain in words. So it can be really challenging for them because they'll feel like something bad will happen. I'll get sick. I won't feel right, but it's really vague. So some common compulsions that kids have to neutralize that feeling that comes from the obsessions is repeating. So doing the same thing, rereading. But it's common for kids to reread books. So I'm hesitant in saying rereading because that can be comforting for kids when they're learning to read. This is more like rereading the same sentence in the book 3 times to be being specific about it. Reassurance seeking, so constantly asking questions, often to parents, like kids will want to make sure that parents love them and really seeking that reassurance often. Or reassurance in other ways, like about if they're proud of them too. Avoiding contamination or washing their hands is a really common one with kids. and needing things to be a certain way. So a need for symmetry, lining things up, tapping a certain amount of times can be common with kiddos. So how kids understand it is they'll often call OCD a worry or say, my brain is telling me this, because there's a little bit of they know a little that what they're thinking isn't really what they believe. There's a little bit of that insight even with kids. So how do we treat this? We do EXRP, or exposure and response prevention, with the kids too, but it looks a little different than with adults. A lot of play and psychoeducation, so helping them understand that when these thoughts come in, that it's an intrusive thought and it's not their own unique perspective, and externalizing it. So calling OCD like the OCD monster or the bully in their brain. And maybe we even do art therapy around that. So have them draw it. So then when they hear those thoughts, they can kind of have an image for that to help get them through it. And to do specifically the opposite of what OCD wants, we teach them. Parents are super involved in this and are essential in kind of helping the kids work through it too. So one example of exposure with that would be purposely not washing hands when they touch something that typically that they would want to, or purposely doing something that isn't perfect. So maybe making ugly art. I'm very art in my approach, so I'm going to bring up art a lot, but making something specifically ugly that you don't want to hang on the wall. Using a bravery chart is pretty big too, because we're really asking these kids to be super brave, doing the exact opposite of what is comfortable. So gradually increasing that tolerance in the amount of bravery they can do. That's pretty much it with kids. In adolescents, it's very similar, but there's a little more insight there. So they'll often feel embarrassed or ashamed of the intrusive thoughts, where kids will just not like them as much. So it looks a little bit different with adolescents. I know that was kind of a lot. Was there any questions about that with kids?
Yeah, when would you actually then pass it on for medication? Like if you're working with a client and you see like they need a little something else, when do you feel as a therapist that you would say, hey, you would call, Dr. Patel and say, I think that, can you like evaluate my client? Like when does that happen, I guess, in your treatment?
So when they can't tolerate the discomfort to the effect that they can get through the exposures. So because really OCD is overestimating threat and underestimating what the body can handle. But when those symptoms are a little too strong that we can't get through the exposures, that's when medication can be really helpful. It lowers the baseline of where we're starting so that we can do more exposure.
That's perfect. Thank you. And I think I'll pass it back to Dr. Patel to share kind of then how you would both collaborate together if you had a case specifically that was like this. What would be next? What's our next step, Dr. Patel?
Thank you. No, that's exactly right. Usually the best timing around pairing medications and therapy is recognizing, the child's ability to participate in therapy and in the skills that they're trying to learn to defeat, let's say, the OCD monster, to deal with some of the, anxiety that it might be causing them. And so when I speak to parents and kids around medications, I always describe it as a tool to help them better participate in therapy, but also as a tool to leave therapy feeling less stressed. So sometimes kids, feel very intense things during therapy, and then it kind of creates a lot of barriers to continue on or feel positive about their participation. And so we talk about using medication as a tool to create some of that positive engagement in therapy and learn the skills that they need to learn to manage this, for most people, chronic issue, right? Something like OCD is usually chronic, waxes and wanes throughout your lifespan. And so when we're thinking about children, myself and Dr. Dean are usually always thinking like developmentally around how this is going to affect their development, their transitions from, let's say, childhood to adulthood. And medication can be a very useful tool to help maintain some of those developmental milestones that we're looking for. So usually I have that conversation and set expectations around what medication can and cannot do. So specifically with OCD, it has been shown to be very effective in conjunction with therapy for the greatest success in remission of symptoms and maintenance of remission of symptoms. So what I mean by that is we oftentimes assess what is the disruption, right? Like, is this child, for example, able to go to school, able to socialize, able to interact with their family, and in what ways? And we sort of take account of that in the beginning and create goals of what they want to work towards with the combination of meds and therapy. And usually it's a decreased disruption, right? So to be able to show up to school and stay in class longer, or to be able to socialize with friends and not feel so anxious that you're, coming off as awkward or anxious and not able to, get what you want from interactions with kids. So we think about a lot of those things, set expectations, and like Dr. Dean said, start the medication low. I think, depending on the child and the family and the accommodations, our goal is always to use the lowest possible dose for the greatest amount of success. And so although we do use higher doses for OCD, and we keep that in the back of our mind to make sure that we're pushing to levels that can be helpful, we're also always assessing at every point to see how you're doing, what your goals are, and whether or not you're working towards meeting them as a whole, like the kid, the family, everyone, teachers. We really collaborate with therapists to make sure that everyone feels comfortable with the trajectory of the treatment. But that, in my experience, that's been the most successful, is to work very closely with everyone involved, with the person and even adults, to really make sure that we're optimizing treatment with medication and therapy, and setting the kids up for success.
That's awesome. It really sounds like it truly is a collaborative effort, and like building your right teams, that your therapist and psychiatrist work together, right? Because that's the hope. So I appreciate everyone even contributing to this conversation. So Konstantin, I'd love to actually bring it back to you. Just, you kind of touched about this earlier, but when do you feel the same when you're working with your clients, with adults, right? So that is it the same that when you're in your treatment, you're like, you know what, I need to call Dr. Dean to have him come in, and so that you can build your team with adults too?
Sure. So, yeah, there's several sort of entry points. So, one thing I just kind of wanted to highlight is that in therapy, when we're thinking about asking either kids, adolescents, or adults to do something that's challenging, to do that exposure piece of it, we create what's called a hierarchy of exposures, right? We don't just jump into the hardest thing, right? We really try to build resilience. We really try to build comfort and confidence overcoming smaller obstacles or the smaller challenges, just so that the person is willing and able to kind of move on the hierarchy to some more challenging ones. So I do want to kind of highlight that piece. Oftentimes, to kind of piggyback on what Alexa was saying, is that sometimes it's challenging to start. Sometimes the OCD concerns are so vast and so strong that sometimes people don't leave houses or don't leave their rooms, and in that case, it's impossible to start an exposure and response prevention treatment. So that is definitely where I think we're going to be reaching out, Dr. Patel and Dr. Dean, just to kind of get the person going. And another thing that I've noticed is that even if it's not that severe, just to kind of get the person going, even in the first few exposures, they feel a little bit better if they're a little bit more leveled to start. So I think sometimes when there's some challenges in willingness to give it a go, sometimes the medication could really do wonders to get the person to get going. So those are the two major points where I see medication could be really advantageous. The only other thing I can think about is that when the parents, or let's say significant other of the person I'm working, comes in, sometimes they're just not aware of the best way to support their significant other or their child, because they're not really aware about how OCD works, right? And some of the things that they typically tell them is actually the opposite of what you want, kind of piggybacking on what we talked about earlier about giving into some of the compulsions or actually doing the reassurance seeking. So oftentimes when I do psychoed, of course, we talk about potential role of medication, but we also expand it out, just that psychoed piece, so that everybody in the family is aware of how OCD works, so that they're not, unbeknownst to them, actually contributing to some of the maintenance of the problem by reassurance or by giving in to the compulsion. So in that comprehensive picture, we talk about how much therapy can help. We talk about some of the ways that the family can help, and we obviously talk about how medication can help. So it's really more of kind of, as I said, a comprehensive way to approach somebody who's struggling with OCD.
And I'm glad that you brought up the family piece, because what is happening in session, it's so helpful when it can translate to at home or any, work, all of those things, because again, it's the collaboration part. I think that's like our key word. Dr.
That's absolutely true. Absolutely true. And it's if the family is unaware about how OCD works, they usually employ strategies. Somebody who's just worries about things, like, don't worry about it. It's okay. Reassurance, just because they think this is the way they would like to be nurtured and soothed in some of these instances. And as we've been talking about today, OCD really works very differently than your regular anxiety. So that piece goes really a long way in the treatment.
Absolutely. Dr. Dean, would you like to add anything to that about medication and working with adults as well, just to piggyback off of Dr. Lukin?
Yeah, sure. An analogy that I use often is, like, let's say you hurt your knee, you injured your knee, and now you need physical therapy. But it's painful, so you take like an Advil or some kind of pain-killing medication, and then you can do the physical therapy. Either maybe you couldn't do it at all before, now or you could do it but not as much, and now you can push yourself more, right? So no one would say that it's the Advil that made your knee better, right? The Advil facilitated the physical therapy. So that's how I think of how this kind of works together, that if you're going to have a panic attack when you do your exposure, that's going to be counterproductive, because that actually is going to, it almost shows you like, see, I can't do it. I can't, and even short of that, in any kind of therapy, we all have our limits of how much we can really tolerate before we kind of, have to stop. And so the medication kind of takes the symptoms down and makes them much more manageable. So then you can get much more out of the therapy. A couple of things I'll mention also, which I think just in talking to so many parents in particular for children when they come in, the concern that medication is going to change their child's personality, or the concern that they're going to be stuck on this now for the rest of their lives, or implicitly, though they might not say this, that does it mean that there's something wrong with their parenting or that they've failed or something like that, So one thing I would say is that the medication is not forever. These kinds of things, especially if you're doing therapy, a lot of times it's almost like you're in a rut and you just need something to kind of pull yourself out of that rut, right? But once you're out of the rut, you're on the side, then you're okay. So we're often thinking of these things in terms of like a year or two, 6 months to a year or two, something like that. So that, SSRIs, like I was talking about, like Prozac, Lexapro, you don't get stuck on those. You don't become dependent on them. Obviously when you want to go off of them, you might have to do that kind of carefully with a psychiatrist, but I've never had a patient who got like stuck on something like that. And then the other thing about, is it bad to put children on medication, for instance, or even adults, so we don't take it lightly. Obviously these medications are affecting the brain, and for a child, whose brain is still developing, obviously we don't want to be cavalier about that. But sometimes people will say, like, would you really medicate a child? But in other fields of medicine, you'd never say that, like if a child had cancer, let's say, or diabetes, like, would you really give insulin to a child? Like, yeah, they have diabetes. So I think some of it is kind of, there's still a stigma around mental health, which I understand, obviously. But the flip side of it is that we know that if you go through your whole childhood, with untreated symptoms, we know that that's going to have a negative effect, not only psychologically, but also neurologically, to go through with high levels of anxiety, depression, things like this, OCD. We know that that actually has a negative physical impact on the brain too. So I think what I would end with is the idea that, we have to be careful using medication, but also not treating is not as benign as some people think.
Absolutely. Thank you so much, Dr. Dean. I really appreciate all of that because I think, one, the taking away the stigma is so important that we're even here today to talk about this. And I would love to get everyone's like last little thoughts before we do hop off. Alexa, I do want to bring it back to you. If you have any last thoughts or feelings, and even if you could share when you maybe have had a client that's been like, oh, I think I need this, but I'm not too sure about medication. Like, what has been your technique to kind of be like, hey, let's do this together? Yeah, any last thoughts?
Well, I often give the visual where like you're kind of like living with anxiety up here. So when there's a trigger, you're overflowing. So it feels too much. So I'm like, and medication can just lower you to here so that when we do those exposures, it doesn't feel as intense. And that often is helpful for people to even just see.
Yeah.
I also see that there's a question in the chat about the kids asking questions. I don't think we got to
Yeah.
that. Yeah.
Let's get to that. So the Zoloft question, I think Dr. Dean might have answered that one before, which says 9 to 10 years old. Is that right, Dr. Dean? But then there was another one. What's the best way to redirect repeating questions to ask a kid knows to which a kid knows the answer?
So what you want to gently label the pattern without shame with that first. So to say something like, that sounds like the same question again. I wonder if your brain's feeling unsure, even though you know the answer. Or it sounds like your worry brain's asking, not you. Or, if it is OCD, that it sounds like that OCD monster might be talking. And then also give an answer back. So say, good question. What did we say about that? Or tell me what you already know. Just kind of brings it back to them and back to that insight of knowing that they do know the answer.
Great, thank you. And then Dr. Lukin, any last thoughts or questions or anything else you'd like to share?
Just often, if we're talking about somebody who is, ready to do the exposures, that sort of makes it a little bit more streamlined. Sometimes, as we've talked about here, sometimes people are not completely ready and they go back and forth. That's so common. I work mostly with adolescents and adults, but it's so common for somebody to say, oh, I don't know about meds. Do I really need meds? What about all the side effects of meds? And I always say that, I can't really comment on some of the side effects. That obviously would be for a psychiatrist to do. But let's also, if we label it or talk about it in the same ways, that some of the issues that are being affected in your life, if we consider it a side effect of not treating it from a medical standpoint, I think people can relate to that there's side effects to potentially to taking medication, but there's also side effects for not taking medication. Let's say maybe you're not going out as much, or maybe you're having a hard time getting along in school or with your friends. I don't know, for some reason, when we kind of put it in the same sort of wording, it helps people to start thinking, oh yeah, you're right, me not being on meds and which will help me now to do the exposures will then impact my life positively. For some reason, I've noticed that gives people a little bit more willingness to consider medication and call Dr. Patel or Dr. Dean. That's one thing that I've just noticed that has worked in the past, I don't know, 20 plus years.
Awesome, thank you. And Dr. Patel, any last thoughts that you'd like to share with us?
No, I feel similarly. I'm oftentimes having conversations with people, adults, or even parents around, the risks and benefits of medications, obviously, but then also the risks around worsening anxiety, worsening OCD. And oftentimes, especially, with adolescents, for example, we do work very closely on establishing that rapport and having these conversations, right? We know that the most amount of success comes from buy-in, whether that's for therapy or for medications. And so a lot of our work is done around providing that psychoeducation, at least making an informed decision as a family, and always reassessing whether or not this decision continues to feel right for you, whether you decide to start medications or you decide to wait on starting medications. I think the reassessment and the continual conversation with your psychiatrist and your therapist is absolutely necessary to make sure that you are doing everything that you can to help yourself and to get better. So it's not always a straightforward process for everyone, and that's okay. I think just putting in the time and the effort to talk to your doctor and talk to your therapist of understanding why now may not be the right time, or in the future it may be a better time, is helpful, and always making sure you're getting that expert opinion to, make sure you're not letting your worries or your OCD kind of get in the way of your treatment as well. I would say, being very cognizant of that.
Absolutely. Thank you. Thank you all to our panelists. The last couple of things I'll say to wrap up is that if you do have any questions, do please feel free to reach out to any of us, either whether it be the Lukin Center or the Center for Developmental Psychiatry. We highly encourage, do not do Dr. Google, just because these are definitely questions that you want to kind of like bring to, your medical team and just kind of get further information about it. It's always helpful, and we're all here to help anyone out there. Until the next one. So thank you, everybody. Have a great day.
Thanks so much.
Thank you. Bye.